Welcome to the lab. Every year you go for your blood test. Your doctor calls or sends a letter. Everything is normal, and you feel reassured because the test said so. But what if the test you are being given was designed for a 35-year-old with different health risks? What if the measurements most relevant to how you age to your cognitive health, your cardiovascular risk, your bone density, your hormone function are simply not on the standard panel? What if your test coming back normal means you passed the wrong exam? Today, we are going through 6 blood markers that are not routinely included in the standard annual blood panel for adults over 60 markers that leading geriatric medicine specialists and preventive cardiologists consistently flag as clinically important for healthy aging, and we are going to tell you the exact questions to ask your doctor at your next appointment. Put your notepad away. I have prepared a free PDF cheat sheet with all 6 markers, the optimal reference ranges for adults over 60, which differ from standard lab ranges, and the exact phrasing to use when requesting these tests. It is linked in the video description below, or simply screenshot the reference screens later in the video. Watch the full explanations first. The numbers alone will not give you the context you need to advocate for yourself effectively. Before we go into the 6 markers, I want to ask you something. Have you ever left a doctor's appointment feeling like everything was technically fine, but you still felt that something was being missed? Maybe your fatigue was explained away. Maybe your brain fog was attributed to age. Maybe your joint aches were told to be expected, and the blood test came back normal, so there was nothing to investigate. Write it in the comments, one sentence, because the gap between what a standard blood panel measures and what is actually relevant to how a body ages after 60 is real. And knowing that gap exists is the first step to closing it. Here is the structural problem, and it explains why this gap exists. The standard annual blood panel, typically a complete blood count, a basic or comprehensive metabolic panel, a lipid panel, and thyroid-stimulating hormone, was largely designed around the health risks most common in the general adult population. These tests are excellent at what they do: screening for anemia, kidney and liver function, basic thyroid activity, cholesterol levels, and blood sugar. But after 60, the physiology that determines quality of life and long-term health outcomes shifts. Muscle loss accelerates. Chronic low-grade inflammation increases. Micronutrient deficiencies that are uncommon in younger adults become prevalent. Hormonal shifts change cardiovascular and cognitive risk in ways not captured by basic panels. And the reference ranges printed on lab reports are largely derived from population averages that include all ages and both sexes, meaning that what is classified as normal may not be optimal for a 68-year-old woman or a 72-year-old man. Preventive medicine specialists and geriatric researchers have identified a consistent set of markers that provide substantially more information about aging-related health risk, and that respond to intervention, meaning a test result can actually change with targeted treatment. Marker number 1, homocysteine, homocysteine. Homocysteine is an amino acid that is naturally produced by the body during the metabolism of a dietary protein called methionine. In small amounts, it is normal, but when homocysteine levels remain elevated, it becomes directly damaging to the inner walls of blood vessels, a process that accelerates atherosclerosis independently of cholesterol levels, and it is directly neurotoxic to the hippocampus, the brain region central to memory formation. Research from Oxford University, including the landmark VITACOG trial published in the Proceedings of the National Academy of Sciences, found that elevated homocysteine in older adults was associated with significantly accelerated brain atrophy in the regions associated with Alzheimer's disease. Crucially, the study also found that supplementation with B vitamins, specifically B12, B6, and folic acid, in older adults with elevated homocysteine substantially slowed that atrophy. This is one of the most clinically actionable findings in cognitive aging research of the last 2 decades. The optimal homocysteine level for adults over 60 is below 10 micromoles per liter. Many laboratories use a reference range of up to 15, which is appropriate for young adults but not for healthy aging. An elevated homocysteine level is treatable. The question to ask your doctor: I would like my homocysteine level checked. It is a standard blood test, and it is not typically included in the routine annual panel. Marker number 2, vitamin D, specifically 25-hydroxyvitamin D. Vitamin D is not simply a bone nutrient. It functions as a steroid hormone that regulates over 200 genes involved in immune function, muscle performance, cardiovascular health, and neurological maintenance. Vitamin D receptors are found in virtually every tissue in the body, including the brain. The prevalence of vitamin D insufficiency in adults over 60 is striking. According to National Health and Nutrition Examination Survey data, analyzed by the National Institutes of Health, a substantial proportion of older adults have vitamin D levels that are technically within the normal laboratory range, but below what geriatric research consistently identifies as the optimal range for healthy aging. The standard laboratory reference range defines sufficiency at 30 nanograms per milliliter or above. However, the American Geriatric Society and numerous vitamin D researchers consider the optimal range for adults over 60 to be between 40 and 60 nanograms per milliliter, a target that many older adults do not reach even with standard supplementation doses. Vitamin D deficiency has been associated with increased fall risk, cognitive decline, cardiovascular risk, and impaired immune response. The question to ask: I would like my 25-hydroxyvitamin D level measured, and if it has been measured before, I would like to know the specific number, not just whether it was normal or low. Marker number 3, high sensitivity C-reactive protein, hs-CRP. C-reactive protein is a molecule produced by the liver in response to inflammation anywhere in the body. The standard CRP test is designed to detect acute inflammation. The high-sensitivity version, hs-CRP, is capable of detecting the low-level, chronic, smoldering inflammation that does not produce symptoms, but that is increasingly understood to be one of the primary drivers of cardiovascular disease, cognitive decline, and cancer in older adults. Research published in the New England Journal of Medicine, the Jupiter trial, demonstrated that elevated hs-CRP in people with normal LDL cholesterol was a significant independent predictor of cardiovascular events. A person can have a normal cholesterol result while simultaneously having elevated silent inflammation that significantly raises their cardiac risk. The optimal hs-CRP for cardiovascular health is below 1 milligram per liter. A reading between 1 and 3 indicates moderate risk. Above 3 is high risk, and this is a level many older adults reach without any knowledge of it. The question to ask: I would like a high-sensitivity CRP test, hs-CRP, not the standard CRP. They are different tests. Please specify high sensitivity when requesting it. Marker number 4, vitamin B12, with a critical caveat about how it is measured. B12 is routinely included in many standard blood panels. The problem is that the standard B12 serum test is a poor indicator of functional B12 status in older adults, and the reference range used to classify deficiency is widely considered outdated by neurologists and geriatric specialists. After 60, the absorption of B12 from food decreases for 2 reasons. First, gastric acid production often declines. Second, a significant proportion of older adults develop atrophic gastritis, a chronic inflammation of the stomach lining that further impairs B12 absorption. The standard serum B12 test can show a result within the normal range, while functional B12 at the cellular level is actually deficient. A more accurate picture requires adding methylmalonic acid, abbreviated MMA. Methylmalonic acid accumulates in the blood when B12 is functionally deficient at the cellular level. Even when serum B12 appears normal, functional B12 deficiency is associated with peripheral neuropathy, cognitive decline, megaloblastic anemia, and accelerated brain atrophy, and it is entirely reversible with appropriate supplementation or injection. The question to ask: I would like my B12 checked along with methylmalonic acid. I understand these are 2 separate measurements, but they give a more complete picture of B12 status in someone my age. Marker number 5, ferritin, the measure of your body's iron stores. Standard blood panels typically include hemoglobin and hematocrit. These will detect frank anemia, but hemoglobin can remain in the normal range, while ferritin, the protein that stores iron within cells, is significantly depleted. This condition is called iron deficiency without anemia, and it is more common in older adults than is widely recognized. Iron is required not just for red blood cell production, but for cellular energy metabolism, immune function, and neurological performance. Low ferritin without frank anemia produces symptoms frequently misattributed to aging: persistent fatigue, reduced cognitive sharpness, exercise intolerance, restless leg syndrome, and decreased cold tolerance. On the other side, ferritin can also be elevated in the presence of chronic inflammation, liver disease, or hereditary hemochromatosis, a condition where the body absorbs and stores too much iron. Elevated ferritin is associated with oxidative stress and cardiovascular risk. The optimal ferritin range for adults over 60 is generally between 30 and 100 nanograms per milliliter. The question to ask: I would like serum ferritin measured alongside my standard blood count, not just hemoglobin. They measure different things. Marker number 6, fasting insulin, tested alongside the HbA1c that many doctors already run, but rarely tested on its own. Most adults over 60 who receive an annual blood panel will have an HbA1c included. HbA1c measures average blood sugar over the previous 2 to 3 months. It is an excellent screening tool, but it has a significant blind spot. A person can have a completely normal HbA1c while simultaneously having chronically elevated fasting insulin, a condition called hyperinsulinemia, which is an early stage of insulin resistance that precedes any rise in blood sugar by years, sometimes a decade. During this silent phase, elevated insulin is already driving inflammation, promoting abdominal fat storage, contributing to hypertension, and increasing cardiovascular and cognitive risk, all without a single abnormal glucose reading. Research published in the Journal of Clinical Endocrinology and Metabolism has found that elevated fasting insulin in people with normal glucose is an independent predictor of cardiovascular events in older adults. The optimal fasting insulin is generally considered to be below 8 microunits per milliliter. The standard laboratory normal range extends to 25, far above the level at which metabolic harm begins. Testing fasting insulin alongside HbA1c gives your doctor a picture of not just where your blood sugar is today, but how hard your pancreas is working to keep it there. The question to ask: I would like a fasting insulin level added to my standard blood panel alongside my HbA1c. Take that list to your next appointment. You do not need to ask for all 6 at once. 1 or 2 at a time is enough, and your doctor will guide the sequence based on your history. Grab your free PDF or screenshot the reference tables and subscribe for more lab science. Stay strong, stay safe,